Hi, I'm Dr. Eleonora Teplinsky. I'm a board-certified medical oncologist specializing in the treatment of breast cancer.
And you had really exciting news come out today. Can you share that with us?
So I am going to be writing a book, which is really a patient-centered guide to the mental and physical challenges and concerns faced by younger breast cancer previvors, survivors, stage 4 thrivers. It's a really all-inclusive guide to that younger population where often information is lacking. And so I'm thrilled to have this opportunity.
And why did you feel like information is lacking specifically for this population?
And that's actually one of the themes we've been seeing this week at the San Antonio Breast Cancer Symposium. We think about just the science. A lot of the studies don't include younger women. Some of them require age 40 as a cutoff for enrollment, so meaning you have to be older than 40. Some don't have that cutoff, but you look at the average age, and the average age is 65, 63, and that's not wrong because that is the average age of breast cancer. What we're seeing is a rise in breast cancer in the younger population, and this is a population that really faces unique concerns, more than even just the science, but topics like sexual health and mental health, parenting, fertility, relationships, financial concerns, and there really isn't a comprehensive resource focused on that. All of the books on the market now really don't cater to that population, and while social media is amazing and is such a form of community, there's a lot of misinformation, there's a lot of miracle cures, a lot of toxic positivity at times, so there's really a need, I feel, to put this resource out in the world.
Unfortunately, we're also seeing that patients are being diagnosed younger and younger.
Exactly. We've seen really since 2016, there's been a rise in younger women being diagnosed, and every study that comes out just says under 50, that population is rising, and we don't know why that is, but we have to lean into that and say we really need to support our patients who are going through this, who face challenges, premature and early menopause, infertility, financial insecurity, and so how do we help guide with action and provide our patients with resources? And in the book, we'll have patient stories, we'll have interviews with cancer experts, we'll have evidence-based information. I'm really hoping that this is something that will help women really thrive during and after cancer.
You mentioned that oftentimes in a lot of the research that we're seeing presented this week, women under 40 are often excluded or are really underrepresented. So then how can we take some of that data and apply it to these groups as it comes to determining what is the best course of action?
It's a really great question, and I think one of the challenges in general is how do we take information presented at a congress, at a meeting, and say, what do I do with this come Monday morning? As a patient, how do you say, is this study applicable to me or not? And I think there's a number of factors that we look at. One is really how robust was the study? Was it a small study, 50 patients, or was it 500 or 5,000 patients? So that helps us. What phase is the study in? So is it phase 1, those first in human trials? That's exciting, and that's maybe a promise for the future, but not for Monday. And then, or is it phase 3, which is typically a randomized controlled trial where you have two groups that are randomized to one intervention or another. And so that's going to be a more scientifically robust study. But then you take that data and you look at the patient population. What's the average age of the people in that study? What tumor characteristics did they have? And so then you start to figure out, does my situation or do my tumor characteristics fit with the population studied? And sometimes it's not clear, sometimes we don't know. A big part of it also depends on what's being presented. Is it a new drug where we don't even have FDA approval? So that's also going to be a little bit of a barrier. We have to wait for that FDA approval. So a number of factors, but I think there's a lot of information coming out of this meeting and all meetings that happen. And I think as a patient, my advice is always take that information, bring it to your medical team and say, I saw this, it seems interesting, does it apply to me? Can we talk about it? Should it change or will it change what I'm doing for my disease? And I think the last part of it also keep in mind is that all of the studies talk about a specific breast cancer type. They talk about a specific setting. So we might be talking about HER2 positive in first-line metastatic setting. And that may not apply to everyone with HER2 positive disease. And so I think that's a big part of it as well.
And is there anything that you've learned over the past few days that you think you're going to be taking back to your clinic on Monday?
Oh my gosh, so much. It's a lot. It's overwhelming. We still haven't seen everything yet, and it's a lot to process. But I think some general themes. One is there's a lot of excitement about SERDs. And so SERDs are selective estrogen receptor degraders. They work differently than aromatase inhibitors, where aromatase inhibitors block estrogen production. SERDs actually degrade the estrogen receptor. And we saw an amazing study yesterday that was published in the New England Journal of Medicine about imlunestrant, which is a novel oral SERD, and that's nice because they're oral, so it's a lot easier for patients in metastatic hormone receptor positive HER2 negative breast cancer. But there are SERDs in development for early stage breast cancer. So I think there's been a lot of excitement, a lot of research on SERDs, and one of the things that we need to see are they more effective than aromatase inhibitors, and can they circumvent some of that resistance that happens, especially in metastatic disease? And some of the data we saw yesterday says that it is. And also, what about the toxicity? One of the things that we see all the time is the challenges of the toxicity of endocrine therapy. And we're really hopeful that as we have more data that we'll hopefully see a better toxicity profile. So far in the metastatic breast cancer setting we have, and we'll see what happens in early stage. So SERDs are a big one. Another big kind of overarching theme is antibody drug conjugates. There are actually a number approved already and many more in development, and those are really targeting the tumor in a different way. And so we've seen some data here, more to come, but I think that is really going to be a big part of not just metastatic breast cancer treatment, but hopefully in early stage. And lastly, and again, these are just big themes, but lastly, there's been a great session today about where we can de-escalate. So can we omit surgery for low-risk ductal carcinoma in situ? Can we omit radiation for DCIS? Can we omit a sentinel lymph node biopsy for early stage breast cancer? And so all of these studies, some of them, they've only followed patients for a short period of time, so we'll need the longer follow-up. But all of them, again, are in this de-escalation. Can we improve toxicity while maintaining outcomes? And I think that's just such an important conversation, because more is not always better. And I think some of the data we saw today says that maybe less is more. And so I'm really interested to see how that will evolve in the coming years.
And how do you talk to your patients about less being more? Because I think sometimes that could be a little bit of a hard pill for people to swallow.
Oh, absolutely. I think it can be some of the hardest things, right? I think this is why some of these studies are actually really hard to accrue to, because there's a concern of, do I pull back? I find, I will say in my clinic, sometimes, not always, sometimes it's easier to add, not always, because it comes with more side effects. Pulling back is scary. There's this notion of, what am I doing, right? Am I impacting negatively? And I think this is where it really is just a longer conversation, talking about the data, showing the data. I like to pull out the clinical trial and say, look, here's the graph, and here's the number of patients, and here are the outcomes. But ultimately, it's a partnership, and sometimes patients will tell me, I see the data, I know that this study showed that this is okay to do, or that less is more, but I'm not comfortable, and that's okay. I think it really is that partnership and that communication and making a decision that everyone feels comfortable with, that's still safe and effective.
Is there anything else about this week, about this type of education in general, that you think is important for Breasties to know?
One of the big things is that I think there's so much happening at this meeting, and the science that's presented is in different levels. So we have things that are in the lab still, first in human studies, quality of life outcomes, patient-reported outcomes, big, robust clinical trials. And I think what's challenging is that most of it is really exciting and sets the stage for more work, but is not really applicable in the clinic the following week. And so I think that can be frustrating, because when someone's living with that cancer, you want to have that information immediately. And I think the other part of it too is that sometimes we'll see a meeting that's more skewed on triple negative, or a meeting that's more skewed on hormone receptor positive. And it's not that research isn't being done in that space, it just gets read out and reported at different points. And so I think it's really important to take the information coming out of these congresses, saying it's really exciting, but then again, talking to your doctor of, what does this mean for me?
Thank you so much.
Thank
and
you.
Congratulations again.
Thank you.